now. Good afternoon, everybody. It's my pleasure to participate in this meeting. And as the chairperson has announced, we're going to talk on metabolic modulators in coronary artery disease. Now, as far as the pharmacologic therapy of chronic coronary artery disease is concerned, we have mainly two goals. Number one is to alleviate the symptoms of the patient by use of anti-anginals. And number two is to prevent cardiovascular events. Unfortunately, cardiovascular events have not been prevented by the use of anti-anginals, no matter which class of anti-anginals we use. And prevention actually comes only with the use of aspirin, statins, and ACE inhibitors, as you have just heard from Dr. Sandeep Bansal. We have a large number of anti-anginal drugs that are available to us today. And we unfortunately have got into some kind of a concept that we have a first line approach and a second line approach to treatment of angina. The first line drugs constitute beta blockers, calcium channel blockers, and short acting nitrates. The second line are ivabradine, nicorandil, ranolazine, and trimetazidine. Now let me tell you that this concept is not necessarily based upon any randomized controlled data. In fact, there is not much randomized controlled data available with any of these first line drugs, but it is entirely based upon experience and expert opinion of the past. The amount of data which is available with these so-called second line drugs, particularly with trimetazidine and ranolazine, and even ivabradine, is quite bigger than what is available with the so-called first-line drugs. There has never been a direct comparison between the two groups of drugs to show superiority of one over the other, and no evidence of improved outcomes in chronic coronary artery disease with any of these drugs listed above. In fact, beta blockers have been shown to improve prognosis or reduce mortality only in post-infarction patients when given over a period of about a year or so, and also in those who have left ventricular dysfunction associated with coronary artery disease, particularly when ejection fraction is less than 40%. Apart from these two situations, there has been no data that shows that beta blockers improve prognosis in patients with chronic coronary artery disease. We have two metabolic modulators out of these drugs listed here, namely trimetazidine and ranolazine, and we'll be talking about their role a little bit in the subsequent presentation. Now, ever since in the year 1974, Gould gave us this idea that 50% obstruction in an epicardial coronary artery significantly affects the coronary blood flow, the reserve coronary blood flow in patients with this disease. And 85% obstruction in an epicardial coronary artery actually reduces coronary flow at rest and therefore is classified as critical coronary stenosis. Since then, we have sort of caught on with the concept that coronary artery disease, or ischemic heart disease, as it should be called more appropriately, is actually equivalent to at least 50% obstruction of an epicardial coronary artery or more. And if that is absent, then all sorts of evidences for ischemia, barring a few cases of coronary artery spasm, including the results of exercise stress test by various modalities, are considered false positive if we have less than 50% occlusion of a corresponding coronary artery on coronary angiogram. Unfortunately, that is not necessarily a fact, and as we have learned from experience of past several delays, we know now of a number of examples of severe ischemic heart disease where patients have suffered a myocardial infarction with or without ST elevation, where a significant proportion of patients do not have atherosclerotic coronary artery disease on the angiogram. And the same thing is true with unstable angina, more so in women than in men. So we must change our thinking that rather than calling it atherosclerotic coronary artery disease or coronary artery disease all the time, we should be talking about ischemic heart disease. And the patient actually gets ischemia with symptoms, and we do not find evidence of obstruction on the coronary arteries. Not only that, when patients get interventional treatment, and as Dr. Suman Bhandari was also talking a little while ago, this is data from the COURAGE trial where patients underwent PCI, which was compared with medical therapy. And you can see that at the baseline, as well as at the end of 1 year, 3 years, and even 5 years, the percentage of patients who continued with angina or had new onset angina was absolutely the same, both in the PCI group as well as in the medical therapy group. And this is not necessarily because of the fact that the stents went bad or the patients, some of them, of course, had new lesions, but in others, the coronary arteries were found patent, the stents were found working. So one cannot necessarily say that it is only the obstruction that is responsible for ischemia all the time. And clearly, it is the myocardial cell that we have to consider at the center of this concept, which is suffering from ischemia by more than one mechanism. Most common, of course, is a fixed atherosclerotic narrowing, but there can be other situations such as vasospasm, endothelial dysfunction, microvascular dysfunction, inflammation, and metabolic dysfunction, all of which individually or collectively can result in significant ischemia. Now, as far as these two metabolic modulators are concerned, trimetazidine inhibits mitochondrial ketoacyloethylase, and that results in reduction in free fatty acid oxidation and increases glucose utilization by the ischemic myocardium. Thereby, the myocardium is able to produce more ATPs with less consumption of oxygen, and that helps to relieve ischemia. Ranolazine, it was originally thought, also promotes glucose oxidation, but some doubt has been put on this mechanism of action now, and it is now known that it is known to inhibit late sodium inward current in the plateau phase of the action potential of the myocardial cells, and thereby it prevents intracellular calcium overload, which is a major mechanism of reduction of ischemia by ranolazine. Of course, it also inhibits the late potassium rectifier current, and which is responsible for the minor increases in the QT interval that we see on the electrocardiogram by the use of this drug. Now, this is the data on trimetazidine, and this is a meta-analysis of a number of randomized clinical trials. Most of these trials actually have come from China. Total number of patients is about 1,600 from 13 randomized controlled trials. And you see that there is a significant reduction in weekly anginal episodes when conventional treatment and trimetazidine are combined and compared with conventional treatment, meaning thereby that trimetazidine was used as add-on therapy on patients who are getting some baseline treatment for angina, and the angina was not controlled. Similarly, time to 1 millimeter ST depression was increased significantly when trimetazidine was combined with conventional drugs versus conventional drugs used without trimetazidine and given placebo. Also, trimetazidine has been shown to improve left ventricular ejection fraction in patients with reduced ejection fraction and even in those with congestive cardiac failure. And here is another meta-analysis, again of relatively small studies, but that shows that there is an overall about 6.5% increase in the ejection fraction when trimetazidine is administered to patients with chronic heart failure. 2016 ESC Guidelines for diagnosis and treatment of acute and chronic heart failure actually recommended that in patients with symptomatic heart failure and reduced ejection fraction, one could use trimetazidine as well as ranolazine if they have evidence of ischemia, and that both of these drugs have 2B indication. Now, talking a little bit about ranolazine, there are a number of single drug studies with ranolazine that have shown that ranolazine is effective in relieving anginal episodes, increasing time to 1 millimeter ST depression, and improving parameters on the exercise stress testing when compared to beta blockers or calcium channel blockers, and also as an add-on therapy based on the so-called first-line drugs. Now, the Merlin-Timmy trial, as you all know, which was published a few years ago, was a study in patients with acute coronary syndromes, very large study, but that was a negative study. did not show any beneficial effects of ranolazine on the primary outcome of death, myocardial infarction, or revascularization. But a subgroup analysis of that study, which included approximately 3,500 patients who had prior history of chronic angina before patients were put on ranolazine, it was shown that ranolazine was definitely effective in reducing the chances of worsening angina, addition of new anti-anginal therapy, and also significantly reducing recurrent ischemia as compared to placebo. Although in this subgroup analysis also, there was no difference in cardiovascular death or incidence of myocardial infarction. Then in the RIVER PCI, ranolazine was given to patients who had incomplete revascularization following PCI, and that is not a very uncommon scenario in our day-to-day clinical practice. And this was a multi-center randomized double-blind placebo-controlled trial which looked at the two primary events, namely ischemia-driven revascularization and ischemia-driven hospitalization without revascularization. And both put together in the composite endpoint, you see that there was no significant difference made by ranolazine as compared to placebo, either when both these endpoints are put together or each one of them looked at individually. Now, here is a comparison of relative efficacy of various anti-anginal drugs used as add-on therapy in patients with stable angina. 46 studies and 71 treatment comparisons were made. On the left-hand side is the exercise stress testing outcomes, and on the right-hand side is clinical outcomes, relative rate reductions. And here is beta blockers and calcium channel blockers added, 2 beta blockers, and you see there is an additional increase in the total exercise time, time to ST depression, and time to angina. When beta blockers are added to calcium channel blockers, similar effects are seen. Beta blockers or calcium channel blockers, long-acting nitrates, some improvement seen. Beta blockers or calcium channel blockers plus ranolazine, improvement seen in all three parameters. And similarly, beta blockers or calcium channel blockers with trimetazidine, improvement seen in all these 3 parameters. The same thing was seen when you look at the clinical outcomes, that there was a significant reduction in the clinical parameters were improved significantly by the same combination that I have shown on the left-hand side. And here is the data with ranolazine, beta blocker or calcium channel blocker plus ranolazine, beta blocker or calcium channel blocker plus trimetazidine. So based on all these data which is available, and especially I must add on here that patients of diabetes mellitus are particularly difficult to treat, and both trimetazidine and ranolazine have been shown to have significant effects in patients with ischemic heart disease associated with diabetes. In addition to that, both have been shown to reduce the HbA1c levels to some extent, although data with ranolazine is much more robust than data with trimetazidine, and approximately 0.5% improvement in HbA1c levels has been reported in patients with diabetes, and a slight improvement in HbA1c levels, slight reduction in HbA1c levels has also been shown in people without diabetes. Now, the 2019 ESC guidelines have given the following recommendations, and they continue as first line, second line concept, although everybody does not agree with this. And the first line is beta blockers and or calcium blockers to control heart rate or symptoms. And if the patient is not controlled, then trimetazidine or ranolazine can be added. And in subjects with baseline low heart rate and low blood pressure, obviously where beta blockers and calcium channel blockers cannot be given, ranolazine or trimetazidine may be considered as first-line drug to reduce anginal frequency and improve exercise tolerance. But in my personal opinion, much more important than this is to actually try to figure out what is the actual mechanism by which this particular patient is getting ischemia. Does he have really obstructive coronary artery disease or not? And then take a considered view as to what should be the best combination of drugs for such a patient. So we actually need to shift our focus. We need a fresh look from a plaque-centric approach where we started to believe that 50% or more obstruction is compulsory to call it coronary artery disease, to shift to calling these patients as suffering from ischemic heart disease, and we should treat them with an ischemia relieving approach and individualization of therapy depending upon their pathophysiologic assessment. Thank you very much for your kind attention.
Thank you. Thank you, Professor Sethi, sir. A wonderful presentation, clearing all doubts. But I would like to ask you two questions. Number one is that in your personal experience, how do you select whether trimetazidine is to be given or ranolazine is given to this particular patient in view of the diabetic status of the patient in a diabetic patient? And number two is that what is the mechanism behind reducing the HbA1c by these two drugs?
As far as trimetazidine, let me take the second question first, and then I'll take the first question later. As I said that the data on reduction of HbA1c has been shown with both of these. The data is more robust with ranolazine, and that is perhaps supposed to be because of glucose-mediated insulin release. You know that it has a sodium channel blocking effect, and by blocking the sodium channels in the alpha cells of the pancreas, it reduces glucagon levels. And also the peripheral utilization of glucose gets better. Not only this, there is a drug-drug interaction with metformin, and that is very important to remember because it is known to increase levels of metformin. So that may be an additional factor that in patients who are on metformin, not only that one should not give more than 1,000 milligrams per day or maximum 1,500 milligrams, 1,000 milligrams a day metformin, but this may be one of the mechanisms whereby you can see some improvement in the diabetic status. As far as trimetazidine is concerned, you know that it shifts the metabolism from free fatty acids to glucose, and thereby peripheral utilization of glucose is improved, and that is considered to be one of the possible mechanisms, although the exact mechanism is not known, and very large body of evidence is not available to specifically address this issue. Small studies are there with both of them, and this is sort of kind of the result. Now, how to choose between these two is a question which is not very easy to answer because it is based on personal choice, personal experience, etc. But if we have a diabetic patient, both are effective, more effective, at the metabolic level, and ranolazine has more published data as compared to trimetazidine. Otherwise, it doesn't really make a difference. You can choose whichever you like. Both are hemodynamically neutral. In fact, they are known as non-hemodynamic anti-anginal drugs. They do not affect the heart rate. They do not affect the blood pressure. And you can choose one over the other. If there are some contraindications to use of ranolazine because of BCG changes or some other things, then one can, go to trimetazidine. Personal experience and personal preferences are also very, very important in this situation. And if one is not effective, even they can be combined, and both or single one can be combined with beta blockers or calcium channel blockers or nitrates or any of the other drugs.
Thank you, sir. Dr. Bhargav, please.
Thank you, Dr. Sethi. I thought I should ask you about nicorandil, but your topic is immunomodulator. So, but still, can you just throw light on nicorandil, like whether you consider it as equally effective as the trimetazidine and ranolazine?
See, the data with nicorandil is the least out of all the drugs. Although it's a Japanese drug and much has not been investigated in the United States of America. That is a problem, and that is why we have less data. Combination data is not available at all. We have one IONA study, which was published many years ago with nicorandil that showed some improvement in outcomes, including reduction in mortality. But beyond that, we don't have any data. And neither as a standalone therapy nor as add-on therapy with any of the drugs in which robust exercise stress testing and other things have been performed. But then, again, personal experience says that it is effective. There are some benefits of nicorandil at the microvascular level. It tends to improve that flow from the coronary arteries, and particularly useful during acute interventions. A lot of people use that for no reflow issues and other things. So there is some use to it, but if you ask me the data, Well, I don't have much data to support that.
Yeah, definitely. Like you have mentioned about that during the time before PCI and post PCI, there's significant data is available, and they have shown decrease. Even with trimetrazine, they have used IV, and they have found that the perfusion is better, the arrhythmias is better, the even the event rate is less. So definitely that data is available with Nicorandil.
Acute coronary syndrome, where the
Yeah, acute coronary. Yeah.
a patient who has chronic coronary disease. Not only that, we should call it ischemic heart disease.
Yeah,
Rather than atherosclerotic obstruction of the coronary arteries, there are functional abnormalities, there are metabolic abnormalities, there are inflammatory abnormalities, etc., etc. So this presentation was basically based on data on patients with chronic coronary artery disease.
your presentation was wonderful, as always, actually, and very good presentation on metabolic modulator. Very nice.
Thank you.
Thank you. Thank you, sir.